Hello, everyone. My name is Shika Dunyo, and I'm the Director of Education Programs at NORD, and I'll be your host for today's webinar on open enrollment. This webinar is a part of a free series of educational webinars for patients and caregivers. We're so glad that you're able to join us today, and we hope that you join us for future webinars in the series. Now, I'd like to take this time to introduce my colleagues, Tim Boyd and Paul Meyer. Tim is the Director of State Policy at NORD. In his role, he's responsible for public policy in all 50 states. Prior to joining NORD, Tim worked nationally and globally on HIV and AIDS policy. Paul is the Director of Federal Policy at NORD. In his role, he works on legislative and regulatory advocacy at the federal level. He also engages the FDA and NIH, and prior to joining NORD, Tim worked at the Center for American Progress, AARP, and the United States Senate. Paul, I'll turn it over to you now.
Thank you again, everyone, for joining us today for our webinar on open enrollment. We're actually going to start very broadly with an overview of health insurance in the United States. And the graph that you see in front of you here is about 2 years old now, so the numbers within the graph are probably a little bit outdated. However, this graph shows you a good image and can convey understanding of the various different insurance options that individuals have in the United States for covering their healthcare needs. So here you see various different kinds, such as receiving health insurance from the military, if one is an active duty or retired military member. Medicare, of course, which covers individuals over 65, as well as individuals who qualify for the Social Security Disability Insurance Program. There are a good portion, actually I would say the plurality, of individuals who have health insurance in the United States gain their health insurance from their employer. It's an employer offer plan. And then many others gain their health insurance from state Medicaid program or the Children's Health Insurance Program. And then still others purchase their health insurance through individual private plans. So they don't necessarily get them through their employer. They don't also qualify for a federal program or a state health insurance program. So instead, each year, individual has to sign up for health insurance through either the ACA marketplace or through other private means. So we're not going to talk about every single one of these today. That would take far too long. That's probably a whole seminar's worth of discussion. Today, instead, we're just going to talk about 3 of these kinds of insurances because they're directly relevant to this time of year, right now, October 30th, and that's because we're in open enrollment season. So the 3 kinds of insurance we're going to talk about today are Medicare. That's because open enrollment for Medicare Part D and Medicare Advantage plans is ongoing right now. That runs from October 15th through December 7th. And then we're also going to talk about signing up for private insurance through the health insurance marketplaces that were created as part of the Affordable Care Act. And then in addition to that, one can also sign up for Medicaid through these very same means. So the reason we're talking about that is because open enrollment actually starts in 2 days. It starts on November 1st. And in most states, it ends on December 15th, though there are in a couple of states, such as Minnesota and actually the District of Columbia, different start and end dates. But for the vast majority of states, that open enrollment is November 1st through December 15th. Now we're going to get into all of this a little bit more on how to actually sign up for insurance in Medicare and Medicaid and private insurance. But before we do, we're going to step back to 2009. When the Patient Protection and Affordable Care Act, perhaps more colloquially known as Obamacare, or also Affordable Care Act for short, was passed, and then in 2010 it was signed into law. Now, the Affordable Care Act does a variety of things. It does many things, actually. But the 2 most primary things that it does is it created a new way for purchasing private health insurance through what are called exchanges or marketplaces. And then this private health insurance had to comply with very specific rules, including several pre-existing condition protections, which we'll get into a little bit later. Now, this private insurance is also subsidized for those who make a certain amount, and that's for individuals between 138% of the poverty line and 400% of the poverty line. Now, the Affordable Care Act also expanded Medicaid, and states, due to a Supreme Court decision, can choose whether to take that expansion or not. And currently, we have 33 states and the District of Columbia who have chosen to expand their Medicaid programs to childless adults of up to 138% of the federal poverty line. And we'll get into those numbers a little bit later to bring a little bit of clarity to that. But really the point of this slide is that the Affordable Care Act does many things, and it offers different kinds of coverage. For example, it also would expand coverage requirements for insurance plans to cover children or the children of adults up until the age of 26 if they choose to stay on their parents' plan. It also facilitates ways for employers to purchase insurance for their employees. And then finally, there's other ways of direct enrollment that the ACA facilitates. We're not going to get into those areas quite as much today. Today we're focusing on the marketplaces as well as Medicaid. And with that, I'm going to turn it over to my colleague, Tim Boyd.
Thanks, Paul. So I'm going to start off by talking specifically about the marketplace enrollment. And it's important to know when we're talking about the marketplace, this is for people who are on the individual insurance market, which means you don't have employer-based insurance, you don't have Medicare, you're not on the VA system, or you don't have TRICARE. This is for people who are previously, before the ACA, largely would have been uninsured or would have to purchase, really expensive insurance for themselves. So this is the individual market. And within that market, there are very important distinctions that exist between states, and we're going to get into that a little bit in a couple of slides. But essentially, the map you're seeing in front of you distinguishes between states that operate their own individual marketplace for individual insurance or that they opt into the federal system. In general, most states use the federal system, which is run by Healthcaregov. But there are a few states that actually run their own state-based exchange, and we're going to get into some of those differences. It's a very streamlined process regardless of where you live, and you can find the individual state-based marketplace is just going through healthcare.gov, but there are some distinctions that are worth pointing out. So first of all, when you go, the website to sign up for individual insurance is healthcare.gov. The photo you see on this slide is what that web page looks like today. It shows you that the open enrollment deadline opens this week and will run through December 15th. And as you go through this website, it's very useful, and it has a lot of tools to help you figure out what is the best insurance plan for you. It allows you to kind of include your medications in there to figure out what type of plan or drug coverage may work best for you. In many cases, it allows you to include your doctor information to make sure your physician might be covered. But in addition, the healthcare.gov portal, if you're looking for individual insurance, is also a great way to find out if you're eligible for Medicaid, because that's kind of the first step before you go on the actual ACA marketplace. If you're Medicaid eligible, the preference is for you to sign up for those plans instead. And so when you go through healthcare.gov, when you put in your information, it will check if you're eligible for Medicaid, and that eligibility varies by states. This map from the Kaiser Family Foundation looks at what the eligibility is across different states. The ones there in dark blue have a more robust eligibility for childless adults. So essentially, if you do not have a kid and you're just looking for Medicaid for yourself, if you're living in one of those dark blue states, you're allowed to make more money before and still be eligible for Medicaid. Those orange states generally don't have that high of eligibility, financial eligibility for childless adults. So if you live in a state and you're applying for Medicaid and you're looking for individual insurance, you may be eligible if you live in one of these dark blue states. And I'm not going to get into a huge amount of kind of what the income variations are. You'll find that through healthcare.gov, and that process is very seamless. What is important to understand is that when you're going to healthcare.gov, it'll also be checking your eligibility for Medicaid. And just one quick note on the eligibility. This may not be clear at the outfront, but the basic cutoff that Medicaid uses and most other programs use is a determination of federal poverty limit. So the actual screenshot here shows what you're going to see when you actually go through healthcare.gov. The income question is going to ask you. The poverty line right now federally is $16,735 for an individual. So if you make $16,735 or less, you are likely to be eligible for Medicaid in many states. If you make a lot more than that, you may not be eligible. And again, it's the first step when you sign up when you go through healthcare.gov. So this is a slide that really covers some important considerations regardless of the type of insurance you're seeking. So even if you have an employer-based plan, if you're on Medicare, if you're on Medicaid, if you're looking for an ACA marketplace plan, this slide is these are important considerations you always need to think about. First and foremost, if you are reliant on certain medications, making sure those medications are covered under your insurance plan is a very important consideration. As I mentioned before, when you go to healthcare.gov, you can put in information that will tell you whether the plan you're shopping for covers your medications. The same thing can be done on Medicare, which we'll cover later. In addition, you need to look at the benefit structure within your healthcare plan. So even if a healthcare plan covers your medications, it may have different cost-sharing tiers for certain medications. So if you have certain cancer therapies or a new drug that was just approved for your disease from the FDA, you may be required to pay a significant amount of cost-sharing depending on the type of therapy. So it's important to review that and understand what type of coverage you may have available to you. I mean, you may see health plans that have higher premiums, the amount you have to pay each month, but even though they have higher premiums, they have lower cost-sharing for the medication itself. So don't always be fooled by that sticker price of the plan. You really need to think about what the individual components are of it and how much your individual therapies are going to cost through it. In addition, you need to think about the provider and hospital network. Not all health insurance plans, especially on the ACA healthcare.gov marketplace, cover the same doctors. That varies state by state. Obviously, it also varies plan by plan. Oftentimes, you will see in certain plans that they say they have a robust network of providers, they have a really low premium, they have a low cost sharing with it, but then when you dig into it, you realize like they exclude your local medical centers, like the place where you get all your care may not be covered. So it's important to know if your doctor and your preferred providers are going to be in network within that health insurance plan. And again, if you have that information about who your providers are, healthcare.gov lets you check for that. It's also important to understand what the out-of-pocket limits are, how much money your insurance plan is going to require you to pay over the course of the year, both in deductibles and other forms of out-of-pocket costs. So a quick note about something folks may be aware or may have heard more about regarding short-term limited duration plans and association health plans. We have seen as the White House has tried to move away from ACA-based insurance and give people more options other than Obamacare-type insurance, that there's a lot of different new types of or repackaged types of insurance out there that may be cheaper and more affordable. These are referred to as short-term limited duration plans. At times you may hear referred to as a farm plan or an association-type health plan or something offered through a group of employers or your church or something like that. These forms of insurance are not subject to the same protections as the Affordable Care Act. So the reason they're being offered is for people who don't want to have all the protections of the ACA, and so therefore they would be able to buy cheaper insurance. But they can sometimes be sold or advertised as full coverage insurance, but they're not that. So it's important when you're looking through things, if you're not shopping for a health plan through healthcare.gov and you're on the individual market, you may be actually purchasing one of these plans and not an ACA compliant plan. And so there's a couple of key considerations there. One, these plans are not guaranteed issue. They can discriminate against people with pre-existing conditions. They have a tremendous number of benefit exclusions. They are not subject to community rating, which means that short-term plans and association health plans can charge you more because you're more sick than other people, and they don't have a basic level of essential health benefits. And they also don't have annual lifetime limits. So they are, in many ways, they are insurance in name only, but it can seem, if you don't look closely enough, they may seem like an affordable coverage option until you realize they don't have a lot of the protections that a healthcare.gov ACA marketplace plans have in place. The other reason that NORD is so concerned about these plans is because we're really worried that they are going to pull the healthiest people out of the insurance market and make insurance generally more expensive for everyone else who needs more coverage. And so even if you are someone who is completely healthy, you have no severe health care needs, you really just want your doctor visit once a year and that's it, it's important to think not only for yourself, about getting more comprehensive insurance through healthcare.gov or the ACA marketplaces, but to think about the impact it'll have on the market as a whole, and the fact that you as an individual, even if you are healthy, if you buy a more comprehensive plan, that actually helps and keep insurance affordable and comprehensive for people who have larger healthcare needs and may not be able to have as much flexibility as you. So we wanted to show on this slide an example of a screen that you will see in shopping for insurance on healthcare.gov. So this is an example of a UPMC health plan in a silver plan that shows you kind of the breakdown of monthly premiums, deductibles, out-of-pocket maximums, co-payments, and co-insurance, and estimated total yearly cost. I know a lot of that can be confusing. Essentially, the monthly premium is the amount you will have to pay each month just to stay enrolled in that plan. The deductible is the amount of money, for those of you who aren't aware, that you have to pay once you're on that plan before your insurance kicks in. So say you have an injury and you go to the hospital, your deductible would be, say you have to pay $1,200, or in this case $3,500 on this example on the webinar, before your insurance will actually pay anything. And then in this plan, there's an out-of-pocket maximum of $7,350, which means that the most you can possibly pay out of pocket will be $7,350. So those are all important numbers to think about when you're enrolling or choosing a plan. In addition, you can see healthcare.gov will give you information about, okay, what your copay is for drugs, generic versus branded, and whether your providers are covered or your prescriptions are covered. So when you enroll through insurance through healthcare.gov, you will see an example like this for each plan offered in your network. And depending on where you live, you may have different plans available to you. So some of you, if you're on the individual market, you'll see when you go to put all in your information, you'll see maybe 3 or 4 different health plans that you're able to choose from. In California, you may see 10 to 12 different health plans that you can choose from. But in some states, there's only one person on the exchange, and you may only have one option. But regardless, it's important to look at the different coverage options within that plan and at least know what you're going to be covered for and what not. So we wanted to kind of actually pause here where we're talking about things to know about your health plan to tell you all about an issue that has come up that some of you may have already been exposed to. You may have heard other information from Nord about this regarding copay accumulators. Essentially, what this is that many patients on therapies rely on copay assistance. They get a drug discount card, or they get some kind of assistance card from a drug company that helps pay for their medications each month. And up until recently, this copay assistance would apply to your insurance costs, which means it would apply towards your deductible, it would apply towards your copay. And so even though your drug under your insurance might cost $1,000 each month, the copay card would cover all of that, and you, over the course of the year, may not have to pay anything. But what we're seeing is, due to changes in technology and the ability of insurers to track how certain things are paid for at the pharmacy level, we're seeing more and more insurers now not allow that copay assistance to apply towards those insurance plan costs. So no longer allowing copay assistance to apply towards deductibles, no longer allowing it to apply towards your copay. And as a result, what we're seeing is that patients who in the past have had nearly no cost because of a copay card from their drug company are now subject to $400, $500 costs at the middle of the year, even higher over the course of the year that they wouldn't have had to pay before. We're really concerned about the impact this has on access and access to other medical care services. But essentially, it's an important consideration to think about when you're enrolling for insurance. So it is highly likely, depending on your plan, that there will be language in your plan with this policy and telling you that if you use a copay card, if you use a drug assistance card, it is not going to apply to your insurance costs. And so we have a couple slides here to try to illustrate what this looks like in practice. And I know this one can be a bit confusing, but essentially, before an accumulator program was put in place, if you look at the far right column there, the one in yellow or orange, depending on your screen, you'll see that before an accumulator program was put in place, a patient would essentially have no cost so long as they have that drug assistance card. That's because the amount covered by that copay card would go towards their deductible, and then once the deductible was met, the insurance would kick in and pay for everything else. So under this before example, the insurer would pay $12,000, the copay card would be worth $6,000, and the patient would essentially have to pay nothing over the course of the year. After an accumulator program is put in place, what we've seen happen is that because that copay assistance no longer applies towards the deductible, no longer applies towards out-of-pocket costs, the insurer is actually paying less, and all those costs are being passed directly on to the patient. So in this example, under the previous slide, the patient had to pay $0 over the course of the year for their medication. With an accumulator program in place, the patient may have to pay as much as $4,800 under this example. So it's important to know within your plan whether that language exists, and it can be kind of tricky to identify. In some plans, it's buried at the back of the insurance policy document and pays like $157. When we send the slides around from this webinar, we're going to include a couple examples of what that language may look like, so you can see within your plan if you are going to be subject to an accumulator or not. In addition, you can always talk directly to your insurer to ask them about that even before you enroll. And so in terms of what NORD is trying to do with accumulators, first and foremost, we are really trying to spread the word, which is why we're raising it on this webinar. We've had separate press calls where we've talked about the importance of accumulators as well. We're also working, there is state legislation being pursued in several states right now that will protect some patients from accumulators, especially if they're in a state-regulated plan. We're supporting legislation to that effect in New Jersey and other states. In addition, there are a handful of states where if you're on the marketplace, if you're on the healthcare.gov, you will have some protection from accumulators just based on laws that exist capping out-of-pocket costs and out-of-pocket drug costs in general. In addition, NORD and other patient groups that we're working with continue to work with regulators and state officials to try to prevent further proliferation of accumulators and prevent these from being implemented and find ways to actually roll them back and protect patients across the board. So we're actually going to switch it up here to talk a little bit about the state exchanges. So you heard me mention at the top, if I go back to the map we were showing, that there are some states that have their own exchange. They don't use healthcare.gov. You can still find insurance through those states, but they actually have their own insurance program. And this is a list of states. There are 11 states in D.C. that operate their own individual insurance market. Again, these states do not use the federal government marketplace for enrollment. So if you lived in California or Massachusetts, for instance, and you went to enroll in an individual plan, you went to healthcare.gov, you're going to put in your information, but that website is going to refer you and link you out to your state-based insurance exchange. So you'll sign up through your state. You're not going to sign up through healthcare.gov. And for those of you who live in states that have one of these 11 states, you may recognize some of these logos. So these state-based exchanges have different names in different states. So in California, their Obamacare marketplace, their ACA marketplace, is called Covered California. In Connecticut, it's Access Health CT. And in Massachusetts, it's the Health Connector. So there are different programs that are branded different ways, but they're all essentially the state-based individual marketplaces. And you can go directly to these websites in those states to enroll in the individual market. And there are some important aspects of these. The reason we're just talking about this is because there's important differences that can occur whether there's a state exchange or they're relying on the federal exchange. Generally, these plans are the same, so you're not going to see a huge difference, but there are a couple key things that may be different. For one, states that operate their own marketplace for individual insurance have a little bit more discretion on which insurers participate and can require benefits above and beyond kind of a floor of benefits that the federal government uses. So you may find in California, if you're on the individual market, you have different types of plans available to you. Those plans include more benefits and may have different costs. In addition, because the states have, if they run their own exchange, can limit the number of insurers that participate, they have a little bit more flexibility to negotiate, and they can try to drive rates down by allowing or requiring insurers to compete to actually be on the marketplace. In addition, states have the ability to kind of tailor what the plans and the insurers look like more closely to the needs of their population. So if a state knows they may have more long-term care needs or want to specifically address, say, medication costs or something like that, they can tailor plans more specific to their needs than they would be able to if they just relied on the federal exchange. So a few important takeaways before we pivot over to Medicare. One, as Paul pointed out at the outset, the Affordable Care Act is still very much alive and well. The Affordable Care Act is still governing a lot of rules around the purchasing and selling and operation of insurance in several markets, and most notably in the individual insurance market. There's more to the ACA than Medicaid and the exchanges. I know we've talked a lot here about the exchanges and open enrollment, but there's actually the protections that exist for pre-existing conditions and other protections like that apply throughout the insurance market, and so that's why we're so concerned about new plans coming out from the Trump administration that may dilute that market and actually make insurance weaker and more costly for people with pre-existing conditions. And it's important to note, again, that if you're going through a federal exchange, your deadline for signing up on the individual market is December 15th. There can be a little bit of variance in individual states, and there are also some exceptions to be made if you live in the state that has been recently hit by a disaster. So if you live in North Carolina, for example, you may have a little bit later deadline for sign up. All that information you can find on healthcare.gov. And I'm going to hand it back to Paul to talk about Medicare.
All right. Well, thank you very much, Tim. Just as a quick reminder, feel free to post any questions in the Q&A box over here. We'll be taking questions at the end of the presentation here on everything we've covered. That's private insurance, that's Medicaid, and now, of course, Medicare, the third kind of insurance that we promised we would talk about today. So Medicare is best known as the government insurance option for those who are 65 years and older. Medicare was first created in 1965, and while it covers primarily those who are 65 years and older, it also covers individuals who qualify for the Social Security Disability Insurance Program. You all may be familiar with the Social Security Disability Insurance Program. This is another federal program that's overseen by the Social Security Administration, and it offers disability insurance to individuals who are no longer able to work due to some sort of disability that prevents them from finding gainful employment. So if one qualifies for Social Security Disability Insurance, then following, for the most part, a 2-year waiting period, they will also qualify for Medicare coverage. I say for the most part because there are some exceptions that actually speed this process up, but by and large, there is a 2-year waiting period between qualifying for SSDI and then gaining Medicare. Now, qualifying for SSDI is its own complicated and process, but before I get to that very briefly, just actually two additional communities who automatically qualify for Medicare, those who have end-stage renal disease and those with ALS or Lou Gehrig's disease. So I'll get back to those who are 65 plus in a second, but for all adults who can qualify for Medicare through the Social Security Disability Insurance Program, the place to go looking for whether or not one would qualify is ssa.gov/apply-for-disability, which is the URL that you see at the bottom of this slide here. This is the web page you see in front of you. This is a screenshot from that web page, and it kind of walks through the various different criteria that the Social Security Administration looks at to ascertain whether or not one would qualify for SSDI. And again, this is its own complicated process that would take its own webinar, so we're not going to get too far into that today. But we just want to be sure that everyone who is either in the process of or hoping to or already does qualify for SSDI, that you also know that this will, at the very least, eventually also qualify you for Medicare. So let's go into the basics of Medicare. There are 4 parts of Medicare that are important for us to know about. There is Medicare Part A, and this is actually the original Medicare in a sense. And Medicare Part A covers everything that happens within the hospital for the most part. So that means it covers the hospital stay. It will also cover some skilled nursing facility care. This is generally if a skilled nursing facility care is required to either rehabilitate from an injury or a fall or something of that sort, as well as if a skilled nursing facility care is required to maintain a specific health level. But Medicare Part A also covers hospice, as well as to some extent it will cover certain home health care as well. Medicare Part B is the physician coverage. So this covers doctor's visits. This would cover preventative care, so going to a physician to have the annual checkup or other preventative care such as other screenings or use of diagnostics. It will also cover the therapies that are actually applied within the physician's office or the outpatient center. So think about chemotherapy or dialysis for that matter. Now I'm going to skip over Part C for a second and go to Part D, which was actually created not too long ago. This is back in 2003 when Congress enacted Medicare Part D, and it first started being active in 2006. And Medicare Part D is for prescription drugs. Now Medicare Part D works a little bit differently in that it actually is a program that facilitates and subsidizes the purchasing of private plans which offer prescription drug coverage. But the intent of Medicare Part D is to, along with Medicare Parts A and B, provide comprehensive health insurance. If you add together the hospital care in Part A, the outpatient care in Part B, and then the drug coverage in Part D, the intent is that this coverage combined will cover all the health care needs of a Medicare beneficiary. Now, Medicare Part C is the alternative. Medicare Part C basically packages Parts A, B, and D into one plan and offers it like a private insurance plan. It's actually rather similar to private insurance. However, it is offered for individuals who are 65 and over or who have a disability who qualify for Medicare. Now, these actually are privately run Medicare plans similar to Medicare Part D that the federal government contracts with and then heavily subsidizes access to that care. Now, Medicare Part C was created in the 90s, which means that it has a bit of a 1990s flavor to it, which means that it has an HMO or managed care style, which for those of you who are familiar with the 1990s type insurance, as you know, has its benefits and its drawbacks. But as one chooses to enroll within Medicare, whether they're just turning 65 and they are thinking about which Medicare option they want to choose, or you're in your open enrollment period right now, one generally would choose between opting in for A, B, and D, or going for Medicare Part C. Now, technically, only Medicare Part A is the so-called required version. You can purchase Medicare Part A, or actually you don't have to purchase it. Technically, you automatically qualify for it. And technically, you can decline to take B and D if you so choose, and some people do. But for a full comprehensive set of health coverage, A, B, and D would need to come together. Okay, so let's talk a little bit about enrollment. As I mentioned, people on Social Security Disability Insurance after a 2-year waiting period automatically qualify for Medicare. And when they do qualify, they are automatically enrolled into Medicare Parts A and B. Now, when we're talking about open enrollment periods, what we're actually talking about is Medicare Part C, or Medicare Advantage, and we're also talking about Medicare Part D. So you're probably wondering, well, what about Medicare Parts A and B? Well, in Medicare Parts A and B, there actually isn't a choice of a plan. You just have one kind of plan, which is facilitated by the federal government. So it really doesn't make sense to have an individual every single year re-enroll unless one chooses to leave A and B for Part C. Instead, you don't have to choose an A and B plan. Instead, you have to choose a Part D plan that would come along with the standard A and B plans. Now, individuals who are 65 and over who qualify for Medicare, they can't necessarily just sign up any time that they want. This is unless they have just turned 65, in which case there is a specific time period that following turning 65, an individual is allowed to sign up for Medicare. For everyone else, so let's say 66 and over, if you've been in the Medicare program for a little while, you have to wait until the open enrollment period to either change plans or sign up for a new plan. And again, that open enrollment period is ongoing right now, October 15th through December 7th. Now, supplemental coverage is also available. This is sometimes called Medicare supplemental insurance coverage. For those of you who watch a fair amount of TV, it's likely you've come across commercials from, I don't know, Humana or AARP or other kinds of organizations that are selling Medicare supplemental insurance. This is also generally known as Medigap insurance, and it's called Medigap because these insurance plans are supposed to cover the gaps that Medicare doesn't cover. Medicare either being Part C or being A, B, and D. Now, Medicare Part, whether you go with A, B, and D or Part C, generally, especially with A, B, and D, there are going to be some things that aren't going to be covered. And Medicare generally covers about from 80 to 85% of healthcare costs for an individual. So for that remaining 15 to 20%, Medigap or Medicare supplemental insurance programs are available to try to cover those additional costs, and one would thus sign up for that kind of insurance in order to supplement their existing Medicare. So the way to sign up for Medicare, one goes to Medicare.gov. This is actually straight from the homepage of Medicare.gov. And as one signs up, you'll eventually find yourself at this Check Your Enrollment box. And this is a very simple Check Your Enrollment process. You enter your zip code because for Medicare Part D, different plans are offered in different places, so it's important that it knows where you are. It requires a Medicare number once you qualify for Medicare. The Centers for Medicare and Medicaid Services, which runs the Medicare program, will send you a Medicare card, which actually I'll go back 2 slides to show you generally what that looks like, at least currently. And then just simple demographic information as well to check whether or not you are currently enrolled, as well as prospects for future enrollment. Now I'm going to spend just a few moments on specifically Medicare Part C, which is also known as Medicare Advantage, and then Medicare Part D, because that's what is directly relevant to our conversation today. Because again, one can choose to sign up for Medicare Advantage and Medicare Part D right now during the open enrollment periods. So, as I said earlier, an open enrollment is running through December 7th. And for Medicare Part C, as compared to Medicare Parts A, B, and D together, there are specific benefits, but there are also some drawbacks. So to talk about the benefits first, for one, there is more of a coordinated care structure, and that might be a bit intuitive considering you're signing up for one plan rather than kind of piecing your health care coverage together from Part A, from Part B, and from Part D. So these insurance plans are meant to be better coordinated and meant to offer better coordinated care. In addition to that, Medicare Advantage plans also oftentimes offer supplemental coverage, which may not be covered in Medicare Parts A, B, and D. An example of that would be dental coverage, and I think I lost a word here because it's supposed to be dental, vision coverage. There can be other kinds of coverage offered through Medicare Advantage or Medicare Part C that's not offered through A, B, and D. But however, there are drawbacks of going the Medicare Part C or Medicare Advantage route rather than A, B, and D. For one, there are generally higher premiums within Medicare Part C. You're paying more upfront out of pocket than you would be if you're paying for Medicare Parts A, B, and D. In addition to that, there is generally a more selective provider network, which means essentially there are going to be fewer providers within that network. Medicare Part B, by and large, offers a very comprehensive provider network across the United States. A lot of physicians, the vast majority of physicians, choose to participate within Medicare. And when we say Medicare, we say Medicare Part B. However, with Medicare Part C, given that it is more of an HMO or a managed care type of plan, it's going to be a much more selective network, which might not cover the physicians that you currently rely on. So it's something to be mindful of as you're considering Medicare Advantage or Medicare Part B. Now over to Medicare Part D, again, the deadline to enroll is December 7th. And within Medicare Part D, you're going to have a lot of different plans to choose from, and that is actually a testament to how well the Medicare Part D program has worked over the course of the last 12 or 13 years since it's been in existence. So on Medicare.gov, you'll eventually find yourself at Medicare Plan Finder, which, similar to Healthcare.gov, allows you to compare the different Medicare plans within your specific area to see what coverage is best for you. And all that advice that Tim gave earlier about checking to see whether your prescription drugs are covered, checking to see what kind of tiers are covered on, whether that be a copayment tier, whether that be a coinsurance tier, and what level of copayment and coinsurance is required, all of that is available on Medicare Plan Finder so that you can compare and contrast various different Medicare Part D plans to make sure that you're choosing the one that's best for you. Now, in order for you to qualify for Medicare Part D, you have to already be on either Medicare Part A or Medicare Part B, or both for that matter. Now, you can't just go off and purchase Medicare Part D if you wanted to and not participate within A and B. And this is intended so that individuals on Medicare Part C are not purchasing Medicare Part D and vice versa. And that's because that would be redundant. That would be duplicative. You don't need both. Now, the cost-sharing structure for Medicare Part D is rather complex. For all of you who are on Medicare right now or are familiar with Medicare, you probably understand that this is a very complex system that the federal government, for some reason, has created, and it might not make a whole lot of sense. So I can't promise that this is going to make sense by the time I'm done explaining this, but hopefully at least it will bring a little bit of clarity. So let's move from the bottom to the top of this graph. So at the very beginning of the year, once you have your Medicare coverage, you have to pay a $415 deductible, meaning that you pay the first $415 worth of prescription drugs in the year. Once you complete that payment, then you start the initial coverage period in which your Medicare plan covers 75% and you pay 25%. Now, once all of that adds up to $3,820 in total costs, and that means both your and the plan's costs, then we get to what is known as the dreaded coverage gap, also known as the Medicare donut hole. Within this, you can see that there are different coverage allowances for branded versus generics. One works their way through the coverage gaps throughout the year as you pay more and more for your medications. Now, finally, once one exhausts the coverage gap, and this happens after the beneficiary has paid out of pocket $5,100 in out-of-pocket costs, or in total the plan has paid $7,654, and that all adds up together, then one enters the catastrophic coverage phase. And in this phase, the Medicare plan, pays 95%, and then you pay 5%. But that goes on in perpetuity. There's actually no out-of-pocket limit within Medicare. If one was hit this coverage, this catastrophic coverage phase in March, then you're going to be paying for 5% of the costs for the remainder of the year. Now, this is the minimum requirements. There are certain plans that can, beef this coverage up a bit more with, more generous cost-sharing requirements. It might be more expensive, but this is the minimum the plans have to cover within the Medicare Part D program. Okay, so that brings to a conclusion our Medicare overview, and actually it brings to a conclusion our overview in general of the 3 different kinds of insurance that you can be looking to purchase or sign up for right now. That would be Medicare, Medicaid through Healthcare.gov, as well as private insurance through Medicare through Healthcare.gov. Now, of course, for employers, there's also oftentimes open enrollment periods this time of year. If you're on an employer plan, keep an eye out for that. That gets very complicated. That's a separate webinar that we can't cover today. We just wanted to cover these 3. But we're hopeful that this webinar thus far has been illuminating and clarifying as you're thinking about how to purchase and if to purchase insurance for yourself or your family or a loved one for next year. So with that, I'm going to turn it over to Tim for some questions from the audience.
Thanks, Paul. So again, if you have questions, you can submit them into the chat box. And I know many of you submitted your questions to us online in registering for this webinar. We have about 12 minutes or so for questions. We're going to do our best to get as many as we can, but if we're not going to answer it, we're going to try to follow up with some responses that kind of cover a lot of your questions in the follow-up from this webinar. In addition, any questions that really dig into personal details and like a lot of disease-specific stuff, we're going to try to stay away from. So if you still have a question that you feel wasn't answered, please feel free to reach out to us at orphan@rarediseases.org or policy@rarediseases.org, and we'll do our best to answer it. So Paul, to start, can you just talk generally, someone who has a disease-specific concern about questions, disease-specific concern about their plan, wants to figure out exactly what their situation would be for insurance plan, like what's the best way for them to get answers to those questions, and regardless of Medicare or ACA?
So that's a really good question, Tim. The best place to start is to talk to your doctor. Talk to your doctor that is best or most aware of the comprehensive care that you need, and that means the kinds of prescription drugs that you might need. That means the kinds of medical devices that you might need. That means the specific physicians that you might need, whether that be your physician, him or herself, or other specialists that you might see, or physical therapy or occupational therapy. Just think about who you can talk to who knows your health care best, and obviously that's going to be you first, but it's always good to talk with your physician about this. And then from talking with your physician and kind of evaluating what specific healthcare needs you expect to require in 2019, then you can either go to healthcare.gov to look at the various different plan options for private insurance, or you can go to medicare.gov to look at the various different options for Medicare. Now, we didn't get too much into the nitty-gritty of how each of these 2 websites work. Thankfully, they're hopefully rather intuitive. But within each of the plan offerings, you can drill into what specific drugs are covered under what tier. Under both Medicare and Healthcare.gov, you can actually put the name of your drug into the list. It's a very comprehensive list. You can click on it, and it will tell you at what level it is covered within that plan, or perhaps not covered at all. You can actually also search plans by physician or by drug. So you can search search, let's say, Dr. Smith in Tulsa, and Oklahoma's on the federal exchange, I believe. So on healthcare.gov, it will say, okay, well, Dr. Smith is covered by these 4 plans. So just think about the specific healthcare needs that you're going to need. It's good to always consult with your doctor on this. And then through healthcare.gov or through medicare.gov, look for the specific offerings, the specific plans that cover that to make sure that you are signing up for a plan that covers your healthcare needs.
All right, so we have a question from Joseph about whether or not NORD has a preference for Blue Cross or Blue Shield within Medicaid managed care plans. It's really, we don't have any kind of preference. I think that the quality of a plan really depends on what they're covering, if your providers are in it, what the cost sharing looks like. And that, even within a single company like Blue Cross Blue Shield, that can vary between plan types that they offer. So there's no real way to say, like, this provider is better. You really have to look at what the specific plan that you're being offered covers. I know within many Medicaid managed care programs, you may not have a lot of choice, but it's just important to look at what that specific plan is offering, what your requirements, cost sharing, or otherwise will be before enrolling. So another question about which marketplace plans in 2019 will include a national PPO network. Again, that depends on the plans that are offered to you in your state. There are marketplace plans which are PPO type structure, which will have a network across the country. There are some that are an HMO type structure that have a very limited network across the country, but will have some availability. In general, most health plans on the marketplace will have some kind of national coverage. There are comprehensive insurance, so they do have that benefit. It's important to note, though, that it's really, I think the core thing you need to look at is kind of what providers are you most interested in. A lot of times, even if your plan itself at the outset says it's not going to say cover a provider out of state, you can appeal and address that within your insurance and ask them about that beforehand. Typically, if you address something with your insurer beforehand, you can have more success at getting it covered.
So we're going to take a couple questions from the folks who submitted questions to us prior to the webinar. Thank you to everyone who submitted a question as you were signing up for the webinar. We really appreciate that. We have a question from Tiffany, and I'm going to pose this question to Tim. Tim, is it better to go with a higher premium but lower deductible, or is it better to go for a lower premium but a higher deductible and higher co-payments?
That's a great question. It depends, and I hate to keep using this answer if it depends on your specific situation, but generally, if you are someone who has higher medical costs, and it's going to have, you're going to have high medical costs throughout the year, either your treatment or your doctors or your specialists or your labs, your MRIs, et cetera, et cetera, et cetera, you generally it would benefit you to pay more in premiums in order to have more robust coverage in terms of the out-of-pocket requirement that you're required to pay. So typically, with an insurance design, if you are paying lower premiums, you have higher cost sharing actually within your insurance design. If you're paying higher premiums, your insurance tends to cover more. And so if you're someone who you're going to have a lot of medical costs, paying a little bit more upfront in terms of your premiums may work out for you better in the long run. But again, it really just depends on your specific situation, which your providers are covered, your in-network versus out-of-network costs, et cetera. But generally, lower premiums means more cost sharing. Higher premiums tends to mean less cost sharing.
We have another question from Joelle, and she asks, how would one switch from Medicaid to Medicare when under 65 with an uncurable disease? So just to revisit Medicare once more, Medicare is open to those who are 65 and over, or those who qualify for Social Security disability insurance. So Joelle, to answer your question, if you're hoping to switch from Medicaid over to Medicare, you or your loved one either must have end-stage renal disease, have amyotrophic lateral sclerosis, ALS, or you would qualify for Social Security disability insurance. So if you're looking to switch from Medicaid to Medicare, go to Social Security or SSA.gov, apologies, it's www.ssa.gov. Look to see if, look at the criteria for signing up and for qualifying for SSDI, and then through that process, you can eventually qualify for Medicare if you are under the age of 65.
So a question from Daniel about whether the government requires repayment of any Medicaid or Medicare coverage payments from the patient's estate. So generally, no, Medicare is not income dependent. So if you are 65 or disabled, you become eligible. There always could be some exceptions to that, but generally your income, if you're 65 in Medicare, 65 or older, your coverage is not income dependent, so the government's not going to try to take money back from you. You've already kind of paid into it through your working life. Within the Medicaid program, there is some of that, not necessarily pulling it from your estate, but there are income thresholds, and there may be instances, certainly within like certain long-term waivers within Medicaid, where if you are above the income threshold, you may have to pay a little bit out of pocket out of your existing income before you become eligible for Medicaid long-term care. Question from Megan about what do you do if none of the plans in your state cover your needed medication? That's a tough one. If you find, for example, that you're enrolling through the marketplace plan, that your medication that you take is not covered, I think your first option may be to contact an insurer directly and ask them about kind of whether that could possibly be covered through an appeal. It's likely if that medication is not covered, there's some extenuating circumstances regarding it being off-label or other issues regarding that you'll have to work out and appeal with your insurer after the fact. There isn't really, that I'm aware of, Paul, a way to like request coverage before the enrolling.
That's correct.
Yeah.
All right, so we have a couple more questions from folks who submitted questions online prior to the start of the webinar. So Corinne asked, when I have asked health insurers if a certain service or treatment is covered, they say that it needs an ICD10 code. And then Corinne asks, how does one get that? So just to back up a little bit, an ICD10 code is a diagnostic code that's used internationally that helps the medical community use the same terminology and the same system to diagnose individuals. So for example, let's say Alzheimer's has a specific ICD10 code, or a lot of rare diseases have specific ICD10 codes. But the problem within the rare disease community is that actually a vast majority of rare diseases do not have an ICD10 code because the medical community, by and large, unfortunately, is not thinking of rare diseases as they're creating these systems. So you all know that there are about 7,000 rare diseases in existence, and right now there are only about 600 ICD10 codes for rare diseases. So the way in which to acquire an ICD10 code is the CDC meets twice a year to take nominations for new ICD10 codes. The CDC will review in these meetings that they hold twice a year, generally in March and in September, whether or not a rare disease, or any disease for that matter, should have an ICD10 code. And then if they agree that yes, this is a disease that doesn't have one currently and it should have a new one, then they will ascertain, they will declare that this rare disease has an ICD10 code. And that makes it a lot easier for insurers to cover care for that specific condition, because now there is a specific way to define what condition the individual has. It makes it much more precise. It makes it much more easy to offer coverage and care for those individuals. So we actually have held webinars in the past on ICD10 codes, and look for more information from us going forward on how to obtain an ICD10 code. Really the first place to go is talk to your disease-specific patient organization. They will be able to tell you if there is one or there is not one. And then if there isn't one, you can partner with your disease patient organization on how to get an ICD10 code going forward.
So we have a couple of questions about income requirements when enrolling on healthcare.gov. So generally, there are not requirements or limitations on income when applying for insurance through healthcare.gov on the individual marketplace. There are, however, income limitations on subsidies. So many of the people who apply for insurance through healthcare.gov are eligible for government subsidies to help them meet their, to pay for that insurance. And those subsidies knock down the price at the point of purchase. Those subsidies are based on kind of a sliding scale of income. People who make less obviously get a higher subsidy, and they kind of tend to be, the subsidies, I think the cutoff for them is about $94,000 of income for a family of 4. So if your family of 4 makes more than about $100,000, you're likely not to be eligible for any kind of subsidy, but you can still purchase a plan through the marketplace. If your family of 4 makes less than that, then you will likely get some kind of subsidy to help you purchase insurance. Paul, can you talk a little bit about a question about the SSDI enrollment period? What does that waiting period look like, and how does Medicare factor into that?
So once one officially qualifies for Social Security disability insurance, and again, go to SSA.gov to learn more about the Social Security disability insurance process for obtaining SSDI, then generally there is a 2-year waiting period in between when one starts their SSDI and then when one officially qualifies for Medicare. Now, there is actually an exemption to this, and that's through the Social Security Compassionate Allowances Program, which is a specific list of diseases, which are mostly rare diseases, that actually that waiting period is waived. Now, there are about 200 some rare diseases that are on the Social Security Compassionate Allowances Program, and if you'd like to look at that list, you can go, again, find it on SSA.gov, or you can simply go to your web browser and search SSACAL, or Social Security Compassionate Allowances. And that actually waives the waiting period of 2 years. However, that again is a very narrow set of diseases for which that waiting period is waived, and by and large, it's going to be 2 years in between when an SSDI determination is accepted and when Medicare kicks in.
Great. And one last question about Medicaid income eligibility. So yes, Medicaid does have income eligibility limits, and you can check. Essentially a simple Google search will show you what your eligibility cutoff is for Medicaid in your state. Also, if you go to healthcare.gov to enroll, you'll find it'll tell you if based on your income whether you're eligible for Medicaid in your state or not. So I realize we have still at least 30 questions in the chat box, and many others of you who submitted questions beforehand. Our policy team we're going to put together a document to send out with these slides and the webinar recap that does our best to answer most questions. Obviously, questions that are very personal in nature, we won't answer publicly, but if you have something that we don't respond to, please feel free to reach out to us. I'll pull up that slide again with our contact info here. And anyone who submitted questions to the box, we're going to do our best to summarize them and put our answers in a document that's sent around along with the slides from this webinar. Shika?
Thank you so much, Paul and Tim, for your presentations. We will follow up with everyone on the webinar and those who've registered with the slides, the document that Paul and Tim are referring to, as well as the recording when that's available. If you have a question that did not get answered or that you didn't submit, email us at education@rarediseases.org and we will answer it as soon as possible. You will receive a short survey after this webinar. Please fill it out. It does help us develop future webinars. And last but not least, thank you so much for joining us and have a wonderful day.